Good evening, everyone. I'm sad that we can't meet in person, but I'm glad that we can meet virtually because, as Dr. Bure says, virtual is better than nothing, and I believe that's the case. So I've come to this meeting for more than a decade now. It's an outstanding meeting where there are very good presentations and updates and excellent teaching for patients about different treatment modalities. And I've focused historically in this meeting on hematopoietic stem cell transplantation. Today will be a little bit different for me because I'll also be giving a brief discussion on CAR T-cell therapy, talking about what this modality is and how it can benefit patients and potential toxicities of this. So I'd like to start talking about CAR T-cells, what they are and how we make them. In a nutshell, a CAR T-cell is a T-cell in most cases taken from the patient and genetically reprogrammed to express a receptor that's not naturally expressed on that T-cell that allows that T-cell to now target antigens or proteins that are expressed on tumor cells so that that T-cell can engage the tumor and then kill it. That's what T-cells are good to do, but they need antigen specificity. So how are CAR T-cells made? Patients usually go to a blood bank and undergo an apheresis procedure. This is a procedure done commonly on patients to collect platelets, a couple of IVs, one in each arm. Blood cells are taken out and then are shipped to a production facility where the CAR T cells are made. Those cells are then put into culture. They're stimulated for a few days. They're exposed in most cases to a viral vector that contains the genes that encode the receptor. Those cells are transduced with that vector and then are made to express a CAR or chimeric antigen receptor that can target different target antigens. Those CAR T cells are then expanded in vitro outside of the body in the laboratory, typically for 7 to 10 days, and then they're frozen. They're shipped back to the facility. Patients are then usually given chemotherapy to try to knock out any immune cells that would compete with those cells, and then those cells are infused intravenously into the patient. Those cells will then proliferate in the patients, usually within the first 1 to 10 days, and then can target the tumor and hopefully eradicate the malignancy. So there are a variety of different types of CAR T cells that have been brought to the clinic. Dr. Bure reviewed several of them just a few minutes ago. The most common target currently that is CAR T cells are directed after are antigens that are expressed on B cells, particularly the CD19 antigen that's expressed on the majority of ALL cells and CLL cells and lymphoma cells. Some of the early trials about 20 years ago established that CAR T cells can be manufactured, and over the last 10 to 15 years there have been modifications in the manufacturing method, making initially first generation and second generation CAR T cells that were better proliferating in the body, third generation, and now we're into fourth generation CAR T cells. What's remarkable, though, is that once these cells were modified to the point that they were working, their response rates were really quite high. They were tested initially in patients with the worst disease, usually relapsed or refractory disease like acute lymphocytic leukemia, and had really dramatic response rates with up to 67% of patients in this one study achieving a complete response with completely refractory ALL. Additional studies after the early pilots established that indeed these cells could achieve remissions, and in some cases these remissions were followed out long enough where patients were established to potentially be cured with this type of therapy. Many patients were initially treated with CAR T-cell therapy intended to be a bridge to take them to transplant, but knowing unless they were rendered into a state of minimal residual disease or into a remission, the chance of the transplant curing them would be very low. So this has been an outstanding bridge to achieve a complete response in patients, to take them to transplant and cure them. And now the question comes up as to whether or not you even need to transplant these patients, with patients demonstrating long-term disease-free survival with no subsequent therapy beyond just CAR T cells. So CD19 being the most common antigen is not the only antigen that's targeted on ALL. At the NCI Pediatric Oncology Branch, Patients that have been treated with CAR T cells targeting CD19 that have relapsed have been treated with a second CAR T cell targeting another B cell antigen called CD22. And similar to some of the early CAR T cell therapies, here you can see really dramatic response with the majority of patients that had relapsed refractory disease to CAR T cells achieving a CR with these types of CAR T cells. So the good news is that CAR T cells can achieve responses in patients that have the worst type of disease, relapse disease, and refractory disease. But it's not all good news because there are some challenges with CAR T cells. As Dr. Bure talked about a few minutes ago, one of the limitations with CAR T cells is they currently, in most cases, do not represent an off-the-shelf product. In most cases, you need to manufacture these cells, taking cells from the patients, stimulating them, doing gene therapy on them, and then having to ship them back to the treating facility. There can be challenges with this. Sometimes you can't collect enough lymphocytes from the patient because in many cases they've received lots of chemotherapy and they're very immunosuppressed and they don't have a lot of circulating lymphocytes. Sometimes these cells don't expand in the laboratory or they don't transduce well, so there can be technical challenges. The good news is that about 95% of the time when you do an apheresis and you send cells for transduction, you can usually make these cells. Once you give the cells to patients, there can be relapse that can occur because the tumors can get smart and they can downregulate the target antigen, and that can lead to what we call antigenic loss variants, leading to immune escape and to relapse. Another problem with these cells is they can cause toxicity. When they get in the body and they see their target antigens, they begin to proliferate, and proliferation often translates into the release of chemicals or cytokines that make these cells proliferate, causing something called CRS or cytokine release syndrome, which can cause all kinds of organ toxicity, and I'll go through that in a second. And then the other unmet need with CAR T cells is they're only as good as the antigen that they're targeting. So in hematologic malignancies, many of these B cell antigens are easy targets to go after because in the process of eradicating the malignancy, you also eradicate all of the normal B cells, but the B cells as an off-target are not important for life. You can replace immunoglobulins that B cells make, and you can wipe out all the B cells besides the tumor, and you can do perfectly fine. But if you're targeting an antigen that's expressed on a tissue that's critical for function, then you're going to have significant toxicity to that organ, and in most cases, those types of antigens are not good targets to go after with antibodies or chimeric antigen receptors. So I mentioned before, cytokine release syndrome is one of the toxicities that we see with CAR T cells. About 90 to 95% of patients treated with CD19 CAR T cells will have some type of cytokine release syndrome that can go from mild to severe. In most cases, it's relatively mild, and it's graded as grade 1 to 4. Grade 1 and grade 2 CRS is not life-threatening. Grade 1 is typically just having fevers and chills and constitutional symptoms. Grade 2 is a little bit more severe, where the blood pressure can begin to drop a little bit, and patients have to be treated with IV fluids. They can have chills, and usually this hypotension is mild. Once it becomes more severe, where patients become actually critically ill and need to have vasopressor medications and have to go to the ICU, then they're graded as grade 3 or grade 4 if they develop leaky lungs and have to go on a mechanical ventilator. Those patients are usually treated very quickly with steroids and tocilizumab, an antibody that targets one of the cytokines that T cells use to proliferate and cause CRS, which is IL-6. So we now have a number of FDA-approved CAR T cells that are available. Kymera was approved in 2017 for patients with ALL under the age of 25, having a complete response rate of 81%. Yescarta has been approved since 2017 as well for patients with relapsed or refractory diffuse large B-cell lymphoma and is remarkably responsive with about 40 to 45% of patients achieving long-term disease-free survival, which is incredible if you consider that's just a single one-time treatment. Tocilizumab is an IL-6 receptor blockade antibody that is also approved for cytokine release syndrome as well. And there's multiple new CAR T cells that are being approved and will be approved. You'll see in the next 6 months with a CAR T cell just being approved for relapsed refractory mantle cell lymphoma. So targeting IL-6 has proven to be quite effective in terms of managing cytokine release syndrome. Here you can see data on patients having cytokine release syndrome treated with tocilizumab, usually 1 or 2 doses, and within a few days you see those cytokine levels falling, and patients symptomatically usually have dramatic improvement in things like fevers, constitutional symptoms, and resolution of their hypotension. So that's all I'm going to talk about CAR T cells. I'm going to transition now over to hematopoietic stem cell transplantation. Transplantation can come in 2 different flavors: autologous transplantation, where you use the patient's own hematopoietic progenitor cells to rescue their bone marrow function after you've given them high-dose chemotherapy. The chemotherapy is intended to try to wipe out all of the cancer cells used commonly in patients with relapsed non-Hodgkin's lymphoma or with multiple myeloma. The problem is, as you push the dose of chemotherapy, one of the first organs that you wipe out is the bone marrow, the hematopoietic stem cells. So if you collect those stem cells first, freeze them, and then give the patient chemotherapy, you can rescue their bone marrow function by doing a bone marrow transplant. As I said, it represents first-line therapy for patients with multiple myeloma, where it prolongs progression-free survival. And despite the advent of multiple new highly active drugs in myeloma, autologous transplantation continues to play a role and represents upfront therapy for a significant proportion of patients with myeloma. For patients that have relapsed Hodgkin's disease and non-Hodgkin's lymphoma, it represents second-line therapy, where it prolongs survival in patients with non-Hodgkin's lymphoma and prolongs disease-free survival in patients with Hodgkin's disease. Allogeneic transplants, on the other hand, involve a transplant where you rescue the bone marrow function in a patient after they've received the conditioning regimen with hematopoietic stem cells that come from a donor other than the patient themselves. So this could be a sibling, it could be a mother, a father, it could be a child, it could be a matched unrelated donor, it could be a cord transplant. Stem cells can come from multiple sources. They can come from the blood, called peripheral blood stem cells. They're pushed into the circulation using drugs like plerixafor and G-CSF, and then are collected by an apheresis procedure. They can be harvested from the bone marrow in the operating room by aspirating out stem cells from the iliac crests, or they can be collected at the time of delivery from the placenta, umbilical cord blood, which can be cryopreserved and represents an off-the-shelf hematopoietic stem cell source. So how do transplants cure patients with hematologic malignancies? Those big red lightning bolts represent the conditioning regimen. That's usually high-dose chemotherapy, sometimes radiation. It's intended to try to wipe out those cells in the patients that represent the leukemia. We know, though, in most cases that there's often minimal residual disease or a little bit of tumor that's left behind. And in the process of transplanting the bone marrow or the peripheral blood stem cells, we also transplant immunocompetent lymphoid tissue, and that lymphoid tissue, those immune cells, can generate an immune effect called graft versus leukemia or graft versus tumor, and can render the patient disease-free. So allotransplants are immunotherapy, and that's the way that those of us that perform this procedure think about it. So we know that this GVT, or graft versus leukemia effect, is very potent. Here's a patient that had cutaneous T-cell lymphoma, completely refractory to chemotherapy. They got an allotransplant, had tumor nodules still present in the first month after the transplant, but these immune cells proliferated in the patient and ultimately mounted a graft versus tumor effect and rendered this patient disease-free here 10 years post-transplant with no evidence of disease recurrence and almost certainly cured. There's 2 different types of transplants. There's conventional high-dose transplants that use high-dose conditioning, followed by bone marrow rescue, or reduced intensity transplants, also called mini transplants, that use low-dose conditioning that rely on the immune system to render patients disease-free. The conventional transplants are usually reserved for younger patients that are healthy. The reduced intensity transplants are usually reserved for patients that are older or may have medical comorbidity, where the toxicities associated with high-dose conditioning could be prohibitive. If we look across the country at the types of transplants that are being done, we see that about 58% are using myeloablative conditioning, 42% using reduced intensity conditioning. And when you're considering what kind of regimen to utilize in a patient, there's basically a trade-off. The reduced intensity transplants are associated with a lower risk of mortality because the conditioning is much better tolerated, but it comes at a cost, and that cost is that there's a higher risk of relapse, particularly in diseases like AML. High-intensity conditioning decreases the risk of relapse, but is associated with more toxicity and a higher risk of transplant-related mortality. This is a study that came out last year that shows in patients with AML that were in complete remission that underwent a transplant, that if you look at the B panel, which is the most important, survival, that the patients that got the myeloablative transplant, whether they had no evidence for detectable disease using very, very high-sensitive molecular testing called next-gen sequencing, they did very well, as did the reduced intensity transplant patients, as long as they had no evidence of residual disease. But if that next-gen sequencing picked up any evidence at all of minimal residual disease positivity, those patients were much higher at risk for relapsing, and that had a negative impact on survival. So this is a study that would lead us to believe that looking very carefully at patients' disease status before we transplant them can help determine whether or not we give them a myeloablative transplant or a reduced intensity transplant. Currently, the bias would still be if you could get a myeloablative transplant, if you could tolerate it, that would represent the standard of care for patients with AML. Transplants are getting much safer. In the last 30 years, there's been a significant reduction in the chances of dying from the transplant, with 200-day mortalities being about 20% 25 years ago, and now in this last decade being reduced down to about 10%. So although they're safer, it's still significant risk associated with these procedures. So if you have a 10% 200-day risk of transplant-related mortality, you want to make sure that you're only doing these procedures on patients that need them. So in the era of precision medicine, you might ask, why would we be doing these risky transplants for anybody? Why don't we just use these highly sophisticated, targeted magic bullets? The reason is because for many diseases, allotransplants remain the only curative modality. So for diseases like relapsed AML, relapsed ALL, high-risk MDS, allotransplants still remain pretty much the only therapy that offers any chance for long-term disease-free survival. And for some non-malignant conditions, such as sickle cell anemia or aplastic anemia that's relapsed or refractory to immunosuppression, allotransplantation represents the only curative modality. So just so you get a general idea of how patients do with an allotransplant, if you take patients that have AML and you transplant them, you can see that the chances of them having long-term survival are proportionate to what stage of disease they're in. Those that come to transplant very early on, usually in their first remission, have a much better chance of being cured than those that have a transplant for relapsed refractory disease. So the bias now is that if you have a patient with AML, and if they have either intermediate or non-favorable cytogenetics, the bias is to take those patients to a transplant early. If you look at patients with MDS, you can see that overall about 40% of patients will be cured, with patients with earlier stage disease having a little better outcome than those with advanced disease, although those differences are not all that impressive. So it's great to see new drugs coming along, to see drugs that are able to target different malignancies and to avoid the use for transplantation. And this is just showing the impact of some of these breakthrough drugs. So tyrosine kinase inhibitors came on the scene about 20 years ago, and you can see that there's been a dramatic reduction in the number of allotransplants that have been performed annually for CML. And the bottom line is that's because they don't need an allotransplant. Most patients with CML will achieve a very dramatic response to tyrosine kinase inhibitors and will have long-term disease-free survival and don't need to go through a procedure that could cure them but also could harm them or kill them. MDS, on the other hand, we see a steady increase in the number of transplants that are being performed, and that's because although we've seen improvements with new therapies for MDS, most of these therapies have not proven to be curative, and patients do ultimately get to a state where their disease gets more advanced and gets refractory to therapy, and we can still cure these patients with an allotransplant. CLL with breakthrough therapies like PI3 kinase inhibitors and BTK inhibitors, now we're seeing a dramatic reduction in the number of transplants that are being done for CLL patients. It's very rare now that we get referred a patient with CLL because there's so many drugs that have incredible activity against this disease. So what are the requirements for a transplant? First and foremost, you have to have a donor. If we look at sibling donors, which are preferred choice, this is Mendelian genetics, so the chance that any sibling is going to be an HLA match is going to be 1 in 4. If you don't have an HLA identical sibling, you can look for a matched unrelated donor. If you don't have a matched unrelated donor, you can look for alternative donors like cord blood as a source of transplantation, or you can look at haplotransplant donors. So when we try to pick a graft, our preference is to always use HLA identical siblings. They still have the best outcome in terms of the lowest risk of complications like graft versus host disease and rejection. If you can't find an HLA matched sibling, then we'll look in the matched unrelated registry. There's about 25 million healthy donors in the registry worldwide, and we look for a perfect match. If we can't find a perfect match, then alternative transplants that can be done include partially mismatched unrelated donors, half-matched haploidentical donors, and the great advantage of haplotransplants is that if you're a patient, any of your children will, by definition, be haploidentical. Your parents will be haploidentical, and the chances of a sib being haploidentical is 50%. So the vast majority of patients will have a haplodonor available if that's the only type of transplant that's available for them. And then cord blood transplants are also a alternative. This is just the chances of finding a perfectly matched donor through the registry. So you can see for Caucasians a higher chance than minorities, and that's because the genetic diversity in Caucasians is more restricted, not necessarily them being overrepresented in the donor pool, but more having to do with genetic diversity. Cord blood is collected at the time of delivery from the placenta. It's a very rich source of hematopoietic stem cells. It's frozen. It's an off-the-shelf stem cell product. The great thing about cord blood is that because of the immaturity of the T cells, you can get away with HLA mismatched transplants. So at any one time, if you needed to use a cord transplant, roughly 60 to 80% of patients would have a cord unit available in the public registry that would be suitable for transplantation. And despite HLA mismatching, these transplants have a much lower incidence of graft versus host disease. And when compared to other types of transplants, more recent data suggests that transplant outcome is very similar to transplants using matched unrelated donors. And in some cases, some data suggesting that these graft versus leukemia effects with cord transplants may be stronger than the effects seen with other types of transplants, preventing the risk of relapse. Haplotransplants, I mentioned before, the big advantage is virtually everyone has a haplodonor. These transplants require that after you give chemotherapy and you infuse the half-match transplant, because the T cells will cause lethal graft versus host disease or attack of the normal tissues, you have to give chemotherapy after the stem cell is infused. Usually on day 3 and 4, we give cyclophosphamide to kill those T cells that would be causing GVHD, purging them and selectively eradicating them so that the patient will have engraftment but will not have GVHD caused attacking those mismatched antigens. The great news with haplotransplants is not only are they available for most patients that need a transplant, but recent data suggests that transplant outcome with these mismatched transplants is very similar to transplants using perfectly matched unrelated donors. There's more and more evidence, although mostly retrospective at this point, that outcome is similar to perfectly matched unrelated donors. So if we look across the country at all the different transplants that are being done, you can see the majority use matched unrelated donors, followed by sibling donors, but more recently we've seen an increase in the number of haplotransplants being performed and a reduction in the number of cord transplants being performed. Cord transplants are expensive. They cost anywhere from $45,000 to $60,000 per unit. Haplotransplants can be collected much cheaper and are also more readily available. So I just want to conclude by saying that if you're being considered for a transplant, there's some very important questions that you need to ask. And the first is, does the potential benefit of a transplant justify the risk? And specifically what I mean is, do you have a disease that chemotherapy can cure, or make you live a long time where the risks of doing a transplant are not justified relative to the treatments that are available to control the disease. And as an example, patients with CLL with a P53 mutation or 17p deletion, 10 years ago, those patients would have survivals measured in the range of 1.5 to 2 years with really no effective therapies available for them. Almost all those patients would be referred to transplant centers because we could cure about 50 to 60% of them. Now with the really dramatic success of these new BTK inhibitors and PI3 kinase inhibitors, almost everybody responds to these drugs, and progression-free survival is quite excellent. So we just don't see patients referred anymore, and rightfully so, they shouldn't. The next question is, do you have a disease that can be controlled sufficiently first before you get the transplant to make the transplant worth doing? We know that patients that come into transplant with leukemias that are relapsed will have a very high risk of relapsing after an allotransplant. We prefer them to come in complete remission. So timing is critical, that you receive chemotherapy, that you achieve a remission, and that you try to do the transplant quickly before the disease would relapse. Stem cell donor issue is no longer much of a variable because we have pretty much for almost anyone that needs a transplant, a donor source that's available with the expanded use of mud transplants, cord transplants, and haplotransplants. And then you have to ask, finally, what are the chances the transplant would hurt me? And that means, are you healthy enough to receive a transplant? Are you young enough? We usually don't like to do these procedures on patients that are over the age of 75 because transplant-related mortality, even with reduced intensity conditioning, can be quite high. And then you have to ask about what is your overall physical status? You know, have you received a lot of chemotherapy? Have you been beaten down by it? Have you had organ toxicity to where the risk of going through the conditioning regimen becomes quite high? So you have to be healthy when you come into these procedures. So I'll stop there and thank you all. And I would normally at this point say I'd be happy to take questions, but since this is a virtual meeting, I won't. So thank you.